Welcome to Wellness and Wisdom with me, Dr. Nadu Tuakli. Here you can expect to hear conversations about everything women over 40 care about, from optimal wellness and peak performance, from intimacy to travel and finances and more. I will be speaking to interesting women and sometimes men to educate and motivate you to live your best life. If you want to find out more, please head over to my website, drtuakli.com, or subscribe to my blog. You can also read my book, Sex, Sanity, and Sleep. We are in this together. Welcome back to Wellness and Wisdom. Today we're going to talk about female anatomy and some of the things that can go wrong, especially as women get older, and how to fix them, particularly pelvic floor conditions involving the bladder, such as incontinence frequency and recurrent urinary tract infections, and birth-related issues like fistulae, bowel leakage, prolapse, and difficult bowel movements, and also sexual difficulties. A fistula is an abnormal connection between two different organs. For example, if you have urine coming out of the vagina, or stool coming out of the vagina, or urine coming out of the bowel, it means that those two organs have an abnormal connection, and that's called a fistula. These pelvic organ disorders are significant, but unfortunately, many women suffer in silence because they are too embarrassed to talk about such an intimate topic. As with most silent disorders, they have a significant impact on a woman's quality of life. So my guest today is Dr. Briana Walton. She's a graduate of the University of Cincinnati College of Medicine. She specializes in the field of medicine that combines expertise in gynecology and female urology. She's double board certified in obstetrics and gynecology and female pelvic medicine and reconstructive surgery. She focuses on the diagnosis and treatment of pelvic floor disorders. The pelvic floor, as I said, is rarely talked about, but is very important. And it's a complex of muscles and tissues that support the bladder, the bowel, and the genital organs. Dr. Walton helps women with these pelvic conditions, and she's here today to discuss them in further detail with us. Dr. Walton works with each patient to develop an individualized care plan that identifies the patient's goals and how to achieve them. But first, as always with medicine, education is the key. So we are going to bring light to the pelvic floor and conditions affecting it today. So without further ado, welcome to Wellness and Wisdom, Dr. Walton.
Dr. Tuakli, what a wonderful introduction, and thank you so much. First of all, you summarized the work that I do so succinctly and beautifully. I've had other practitioners who do this work. They can't even articulate it as well as you did. So thank you. I think you're going to be an honorary, the self-described ambassador for the pelvic health. So welcome to the club.
I would love to. I like to get right down there. I'm a big believer.
Hey.
So before we start actually talking about what you do, I'm curious about the gender balancing of the field. Women are still such a minority in urology. And for many women, it's not easy to show their private parts to some unknown male. However, you would think that there would be more women in this business, so to speak. But based on the American Urological Association census data, women accounted for only 10.3% of all practicing urologists in 2020, compared to 7.3% in 2014. And I remember when I was a resident, I did not see a single female in the urology residency program. And yet, studies have shown that half of the patients prefer same-gender urologists. So what's going on?
Yeah, I think there's still a lot of bias, and there is a difference in the uptake of subspecialties between. So for those of us who practice female pelvic medicine and reconstructive surgery, which we've just been renamed as urogynecology, which was very controversial for the urologist, but we're urogynecology and pelvic reconstructive surgery. I think our name now is ERPS instead of
Herbs.
Herbs. It sounds like oops. Which I'm, it is what it is. We're going to have to live with it. But that pathway can be led either through urology or through gynecology, OBGYN, in terms of your residency training. So the number of female providers in OBGYN has increased significantly, but there hasn't really been an uptake in urology. And I wonder if it is related to the training in terms of it really is still kind of monocularly focused on male health as opposed to comprehensive. I think some of the residents and fellows will do some small portion of their training in female pelvic anatomy and female pelvic health. And they come out sometimes, depending on where they're going to practice, at a deficit, so to speak, because they haven't had much training in their residency program. It's not until many people decide to do a fellowship that they are able to gain the knowledge they need to make women feel comfortable, regardless of what gender is. I don't know why, we haven't necessarily, and I know that a lot of the large urology groups are really trying to push to have more women in the field, but it's a slow burden. And it's not that there's not a lot of significant change that I've seen in the 20 plus years now.
And I think because it's a surgical specialty and surgery period is predominantly male, to do that the first year in a general surgery residency, you're
a challenge.
So
yeah, you're correct. I was the first fellow in my program, and then I was the only woman. All of my attendings were male. My colleagues that came after me were all male. So there was a bit of that sort of pressure, so to speak. And I think the concerns about fair treatment and childbearing all came up externally and internally. And fortunately, I just had really good people that I trained with that made me feel comfortable and welcome. I don't think that's the case for many women going through that tracks.
Let's talk about the actual conditions that are involved in pelvic floor reconstruction. Most people have heard of incontinence.
Yes.
Would you say that that's the commonest thing that you take care of?
I would say it's probably balanced somewhere between incontinence and prolapse. So incontinence, as you mentioned, is a term that many women and people in general are familiar with, I think, because it's been socialized on TV. It's in commercials. You've got bladders pulling you around and telling you to go to the bathroom. You've got pads to take care of your light bladder leakage. And so most of us have heard of some form of leakage. But prolapse is not a term that really is normalized, if we can say it that way. It is more, what does that mean? And what do you mean I have a hernia of my organs? Can that happen? There's a bit of disbelief when it comes to bulging of the pelvic organs into the vagina or beyond it.
Can it fall out?
Fall out and hit the floor? No, but it can fall down. You definitely can see it protrude beyond the vagina, and that's generally when people present to me in a state of shock, like, what happened? Why didn't anybody else notice this? What was going on? I've been going to the gynecologist all this time, and they never said anything. We have to think of our visits to the GYN as somewhat, how much time do you spend in the office when you're going to get your annual PAP? It's about 15 to 20 minutes in front of your provider, and, it's like, hi, put your legs up. Entry, insert the speculum, get the PAP eye. And I'm being a little cheeky here, but in the light early stage prolapse, you're not going to see it because you're reducing it when you're doing your exams.
When you lay down.
It's
exactly
symptomatic and or beyond the opening that you're going to actually say, oh, I think you need help.
Right. And I think sometimes a woman can sense that there's pressure down there. Mm-hmm. But then when she comes and she lays on the table, like you said, she puts her legs up and it goes back up in there. The doctor might look around and say, well, everything looks fine because you're laying down. But if you sat up or squatted and then pushed a little bit, you might notice. So I guess that shows that prolapse isn't kind of like an overnight thing. It's gradually been coming down whether you notice it or the doctor notices it,
Exactly.
until you can ignore it no more.
You are right. And time dependent. So I find that sometimes if I see a patient early in the morning for an exam, their degree of prolapse is very different than I would examine it later in the day or after they picked up their kids and they're carrying heavy groceries around. It all depends on their level of activity a few days before and even the day of their exam. So,
And a bad cough.
yeah, right. So I think when I see women and they tell me, no, it's down, I'm like, I believe you. And women have gotten smarter since they've gotten smartphones. So I get all kinds of pictures.
Oh, true. So there's prolapse of the uterus is mostly what we're talking about.
So,
but there can be other kinds of prolapses.
You're correct about the uterus protruding, but the most common is actually the bladder protruding into the vagina, or you can have the rectum pushing up, and that's so cystocele and rectocele, followed by uterine prolapse. And most of the time, it's some degree of composite. We're seeing multiple areas instead of just seeing one. And I think the misnomer is that once a woman has a hysterectomy that they no longer could potentially have anything falling down, but the top of the vagina could also protrude and have a similar presentation.
Now, does it depend on how many children they had or how difficult the deliveries were?
You are so good at this. I mean, you ask the perfect questions. There's a lot of data that is suggestive that women who bear children versus those who don't are at higher risk. Those who have vaginal deliveries and specifically operative deliveries with forceps or vacuum, longer deliveries with the second stage, meaning they're pushing for a longer period of time. All of those factors really increase the risk of the presentation of prolapse and incontinence.
So let's say someone says, I have pressure down there and it doesn't feel good. Are there other symptoms that might clue them in to the fact that there's a problem?
Yeah, besides pressure. So I usually think of this on one side of symptoms or the other. So with prolapse, is almost a folding the tissue, right? And specifically, if it's prolapse of the bladder or the bowel, you can see you have too much of a urinary or bowel symptom or too little. So not emptying your bladder or your bowel, so having to strain to get the urine out or strain to get the stool out, or not being able to control the bladder or the bowel, having incontinence of either the bladder or bowel. Another common symptom is for women to say the stream of their flow is very different. They go to the bathroom, they hear someone else in the stall next to them, they urinate very quickly. And I used to pee like that. Now it comes out slow. It starts, it stops, or it runs down my leg. So those are clues that there might be some change in the anatomy. Some women are actually having to use their hands to support the organs to empty their bladder or their bowel. And then the final, I think, or the final two are starting to see a pattern of infections, more specifically of the bladder, having more urinary tract infections, and then sexual dysfunction, things not feeling the same, something's off, and or it hurts.
Now, I know this is a rarity, but I once had a patient with a myasthenia gravis, and she actually had a uterine prolapse with no history of childbirth. I had to assume that it was related to the muscles that were holding up the uterus, were not holding them as well as they used to. Is that correct?
I think you are 100% correct, and specifically for some of the demyelinating neurologic disorders where you require nerve function to support muscles. And if you think about the vagina like a room, and in the ceiling of the room is bladder, the floor is a rectum at the end, and not for you, obviously, for the audience. At the end of that room, if you walk in the door, is where the uterus is. The walls to your left and your right are the pelvic floor muscles. And in that room, it should be narrow. And so for women who have neurological disorders, it's a very wide room, and they can't contract those muscles to keep the organs from coming out. So eventually, the tissue fails. You've got secondary support and third support with tissue and fascia, stronger ligaments to help keep things in place. But ultimately, over time, they're not going to be able to compensate for poor musculature.
So now we've been diagnosed with prolapse.
Yes.
Are there particular tests that need to be done before we get to the obvious repair, which is surgical?
Yeah, so when I see patients, I will often do just a regular exam. And when I say regular, it takes me about 20 minutes to actually do a complete exam, because I'm not just going straight for the money, right? Looking at their pelvic area. I am doing an abdominal wall assessment to see if there are any identification of relaxation of their abdominal wall muscles, because that kind of correlates with some of the prolapse findings. What kind of scars do they have on their belly to suggest surgery? And then I will do a neurologic exam to identify if there is any sign or symptom of prolapse and in corollary damage as a result of child delivery, meaning that sometimes patients will have deficits in their sensation or deficits in their reflexes. So when I test the reflexes of their pelvic floor, that you don't always see them. We will also do a muscle assessment. So not only how strong their Kegels are, right? Like how much they can contract them, but I would also say the ability to elevate and maintain a contraction for a period of time, which not every provider, when they're saying, oh, you've got prolapse or incontinence, go do Kegels. They're not directing a patient to say, this is how you do a Kegel, or let me assess how well you do them so that we can either allow you to do them autonomously or send you to a pelvic floor physical therapist who can help you regain some of that pelvic floor musculature. Or so, I should say.
So does that mean that you can repair prolapse without surgery?
I think
just by doing the physical therapy for the muscles?
There is a thought that early stage prolapse could be partially corrected with physical therapy. Now, I will say this. Prolapse is not a muscle issue, it's a tissue issue. The tissues have been stretched or torn. The muscles will compensate for sort of damaged tissue. So will it cure it? No. Slow down its progress and potentially ward it off? That's a potential. Will it help if you decide to do something else? It possibly could, depending on the state of those muscles. So very similar to if somebody was in a car accident and they had a spinal injury in their lower back, where they're not completely paralyzed, but they have decreased function. And over time, if they're not walking, those muscles start to shrivel up. We start to see the same thing for women who have had obstetrical trauma or obstetrical drama, where there's either direct trauma to the tissue through with the head passing through, or indirect with us placing instruments inside.
How long does the surgery last? How long does it take to repair it? And how long is the recovery period?
So I'm going to put it this way. So when I see people for surgery who are candidates for surgery, and that usually means that they're symptomatic or it's advanced meaning beyond the opening, I will go down this sort of algorithm in my head. Well, do you want any more kids? And if you do, surgery's not right for us right now. What's your desire for sexual function? Because reconstruction is appropriate for somebody who wants sexual function. And those women who are older and don't want sexual function, I would tend to maybe choose a different route. The third thing that would go in my mind is like, okay, if we've decided surgery, what's my route? Like, am I going through the vagina? Am I going to do a robotic procedure? I'm going to need to use something to help support your tissue with either graft or a mesh, or can I use your tissue itself? And then finally, what's going to be our goals? Because I don't like to walk into a surgical patient without identifying, I know what my goals are in terms of restoring anatomy and potentially restoring function, but I need to hear about what her goals are.
Now, I know you do a lot of robotic surgery.
Mm-hmm.
I guess these days they call it AI, maybe?
Not quite. We're still, it's primary intelligence, not artificial.
But I know you do a lot of robotic surgeries. So what percentage of prolapse repairs do you think are potentially robotic versus needing an open?
Oh, good question. So of my surgical practice, 75% is vaginal and the other 25 is robotic. I haven't done an open case in probably 12 years, 13 years. my learning curve is different than some people because I'm almost at 700 for my robotic surgeries, which, it allows me to be a little more aggressive and comfortable with people who may have more complex conditions versus someone
Right.
who's newer on the robot and maybe isn't comfortable and may need to make an incision in order to do it. I think the question was right. Is robotic surgery replacing open surgery? It should. It should in a large scale and a large number. Does it replace vaginal surgery? It potentially should not, depending on the stage of prolapse and in those goals that we were talking about.
So let's talk about incontinence a little bit.
Okay.
Because you have stool incontinence, which is oftentimes a neurological problem and some other indication of a GI problem. So we'll leave that alone. But urinary incontinence, you have the stress incontinence, you cough, you sneeze, and you wet yourself, or you have the incontinence that's full out where people just can't control it. Is there always a cause for incontinence? Or is it just one of those old age things that women should just say?
That's also good. And I'm just going to put a little caveat on the fecal incontinence because a lot of our patients have had obstetrical trauma on the posterior compartment with either, especially our older patients who had episiotomies and cut through the muscle. So that's a really common reason for people to see me for symptoms related to, I don't deal with the bowel nature loss, but musculature and nerve, as you mentioned. But for urinary incontinence, you're right, we classify it based on symptoms, cough, laugh, sneeze, any increase in pressure or high impact activities, jumping on a trampoline can cause leakage. And that's usually more of an anatomic problem. There's a structural support issue. Or it could be that woman who says, I gotta go, get out of my way. Or as soon as she gets home, she's trying to get the key in the door because she can't get to the bathroom fast enough. She's doing the pee-pee dance at the door. She's squeezing, contracting, and trying not to make a trail on the way to the restroom. And that would be classified as urge. And urge is a cousin to overactive bladder, which I would subclassify as fun. Not fun in the, I'm having so much fun, but fun in terms of frequency, urgency, and nighttime urination with or without wetness. And then surprisingly, there's also functional incontinence, which a lot of those patients are either they've got arthritis, they've got a neurologic problem like Parkinson's, and they just can't get to the bathroom because of their mobility issues. So those are the common ones, but they often live together, not always isolated in a silo. And the nature of those, the presentation is usually multifactorial. It's like one hit, then the second hit, and then the third hit. Being, a woman, that's a genetic risk. Can't change that. Having babies, multiple babies, having obstetrical trauma. Connective tissue-wise, a lot of women who have autoimmune disorders also have a little bit of connective tissue disease that is either subacute or not diagnosed. And then obesity, with any increase in weight. And as we've seen, obesity affects everything.
So I'll have to remember to ask my older ladies, are you having fun yet? That's a good one. Now we have the symptoms of incontinence, the fun going on. Like I said, is this something that every woman gets to look forward to, or is it just the ones that have the risk factors?
So, I'm going to put myself in this situation. I've never had a child. I am fairly healthy, and unfortunately, I have incontinence and had to have surgery for it. So I think it is, it picks and chooses who it wants to show up in and whether we understand the risk factor or not. But we know that in terms of presentation, about 1 in 3 women in the United States will present with some form of a pelvic floor disorder. And the rates of incontinence, particularly stress incontinence, are extremely high, with a very limited number of people actually having some sort of surgical. It's like less than 1% of women who have stress incontinence have any kind of surgical intervention, which is amazing to me still this day.
And the medicines for overactive bladder, in your opinion, are they pretty good? Are they pretty effective?
They have gotten so much better compared to when I first started. There were first generation overactive bladder medications were extremely drying. dry mouth, dry eyes, and constipation with some GI side effects. The second generation had a lot less problem with those secondary effects, but still minor issues. And then the third generation, which are a different classification, you don't see any of those. So what we call anticholinergic side effects, or the sort of the drying effects, or even cognitive. Some women will describe, after being on the medicines for a period of time, a little bit of brain fog. But third generation, you don't really see those side effects. It is more either blood pressure issues, because they're fall in the category of a beta agonist, like a beta blocker, or the opposite of a beta blocker, and or really this GI. So they're much more tolerable in terms of efficacy. We're still in the 50 to 60% range. And we try to look for, if those patients are responding to overactive bladder medications, are they in fact a candidate for something else, like Botox injection of the bladder, or some form of neuromodulation with either an implant or acupuncture.
Now, Botox generally lasts 4 to 6 months. So if you choose to get injections of your bladder with Botox, does that mean you have to do that like 3 times a year?
I'm seeing more about 6 to 8 months in terms of the time for the symptoms to start to return. And most women don't have a sudden return of symptoms that are intolerable. So many women will say, like, I can make it and do it once a year.
Drag it out 9 months.
Mm-hmm. Mm-hmm.
Yeah. So what kinds of sexual difficulties do you see in your practice, and how can you help?
Yeah, I think from a sexual function standpoint, the big categories are, the biggest I would say is pain. And I think pain, because of the population I serve, tends to be a little bit older, and they're having more what we would describe as genital urinary symptoms of menopause. So, menopause is an equal opportunity discriminator. It's going to get your whole body, including your vagina and your bladder. So a lot of those women will describe discomfort with intercourse, not outer course, intercourse. So right at the opening, they'll describe some tearing, pulling, burning, rawness that is, not amenable to position change or lubricants sometimes. The second is probably more just not being able to achieve moisture and lubrication, which also kind of falls under the menopausal changes. And then I would say a lot of women complain of orgasmic changes, or not even knowing if they've ever had an orgasm. A lot of our older patients have never talked to anyone about what is an orgasm, what does it feel like. I'm not sure if I even had one. And so finding myself doing a lot of education around the anatomy of an orgasm, like, what does it look like? How do you know if you had it? And that has been really helpful to just like demystify a lot of the taboo topics, right? That my older patients aren't necessarily comfortable leading a discussion, but are my younger patients who like, I don't want to lose this, or it's starting to go away. So what can you do to make sure it comes back?
And the answer is?
Multiple answers. So
besides taking care of your hormones, obviously.
Yeah. So I think topical vaginal estrogen is our first go-to. We will tend to use a lot to help restore the health of the vagina and the bladder, and that will take care of a lot of the pain issues. Estrogen, I know it's been in prison lately because of its implications.
It doesn't have all those bad implications. It's just hearsay.
Right. So topic.
But it's embedded in the culture.
It is. And so I really try to demystify the use of vaginal estrogen. But some people just don't want to even think about it, and that's okay. So I use a lot of coconut oil. That's my favorite go-to moisturizer for the vagina, because it has some antimicrobial effects to it. Especially if you are just uncomfortable on a daily basis, you can use it, but you can also use it with sexual function, as long as you don't need a condom. I would also say there's newer products over the counter with hyaluronic acid, the same stuff we use on our face, you can use in your vagina. And those are usually paired with like a vitamin E, sometimes some other form of oil, like a jojoba oil. And together they are helpful for the vagina. But part of the reason I started my private practice away from the University of Maryland was to start to look at other energy-based treatments to treat vaginal dryness and pain, which some patients, they can't take estrogens. They've got a estrogen dependent breast cancer and they're on tamoxifen, a drug to keep their estrogen levels lower than natural menopause
and normal.
So using, lasers and radio frequency, we can look at the possibility of, it's almost what we would describe as taking advantage of cellular biology and promoting regeneration. So by doing an injury, like if you cut yourself, you're going to heal with bringing in a scar that has collagen, new blood vessels, growth factors. And so if we cause a micro injury to the tissue with a laser, we can sometimes see that improvement over a process of time by applying it like every 6 weeks with 3 sessions, because we don't want to burn the vagina. We don't want to damage the vagina. We want to injure it in a way that is going to promote healing. And so one of the lasers that I use will help with that. I have a radio frequency device. I don't think it's helpful for that, but it can be helpful for women who describe looseness.
So it sounds to me like you do vaginal rejuvenation.
Yes, that's a great term. It's more of a marketing term, but you're right. Everybody knows it.
And hear about vaginal rejuvenation. What does that mean exactly? And do you actually, are you one of those who believes in injecting the clitoris for improving orgasms? Come on now, let's talk, girl.
We're going to talk. I'm ready. Let's go. I have to tell you, like I've changed. I came from an academic elite background where you would, never even think about these kinds of things. And once I turned 50 and I started asking the questions for myself, and I was like, wait a minute, whoa, let me go and do a little more homework on my own. That's kind of what spurred it. But then I also said, well, if I'm having questions about it, I know patients are having questions, so I need to learn more. And what has happened over time is the American Urogyn Society and the International Urogyn Society have come up with a more of a catchment term for the medical aspect called cosmetic gynecology instead of just rejuvenation, because it can include a lot of different descriptors. And that term rejuvenation could really mean, are you augmenting the tissue with an injection to make a orgasm better, or are you tightening it? Are you improving it, the dryness? Are you reducing the extralabial tissue? Are you lifting the labia up that are floppy? Or are you surgically going in and modifying the tissue to look better? Just not even feel better, but just to look better. Are you placing fillers in the area? Are you sucking fat out? There's a lot of different things that we can do.
Can all fall under that same umbrella.
Yeah.
But I remember hearing a GYN who does the injections of the distal clitoris.
Yes.
And she was claiming that she gets hers injected, I think it was every 6 weeks or something. I have to tell you, it sounded a little odd to me, but this is a new generation. Are you familiar with that? What is it exactly that you're injecting into the clitoris?
So I do injections in the clitoris with platelet-rich plasma, okay?
Okay.
So platelet-rich plasma is not unique to OBGYN. It's been around since the 1970s, and we use it for a lot of different things. It actually has indications in orthopedic surgery, and you'll see your plastic surgeons using it. There's going to be a lot more in regenerative medicine, and it just makes sense if you think about our bodies have the ability to heal ourselves, right? And so if we can pull out the factors like growth factors, like stem cells that can go to a tissue and say, you're damaged. Let me act like, better versions of you, or let's populate you with younger versions of this tissue so that we perform better. That makes sense. Do we understand the science completely? No. How often do you need it? We don't know. How effective is it? Can you give percentages? Nope. You can't say that. So I think that's the challenge that I have with PRP. I think sometimes it can work. Am I promoting it for every patient? No. I will listen to their history and say, oh, I think maybe together with this, or I would consider it for that specific condition. It really is based on their history. How often do I do it? I think it also depends on the patient, in terms of how sexually active you are, and do you actually know where you get an orgasm from? Like, most women do not have an orgasm from vaginal penetration. They have it from clitoral stimulation. And so that's the reason to augment the area, to wake up those tissues. But that the head of the clitoris, the part that we see, the little turtle head sticking out underneath that prepuce or skin fold, right? The skin fold, which you also have to think about it. The skin can cover it too much too. And so rejuvenation can mean pulling the skin back so that there's more exposure. But the internal body of the clitoris, the majority of it is inside next to the urethra, and that's really the G spot. And that's also a place where we inject.
Okay, so you inject the RPR there. I mean, the PRP there, excuse me. And you hope that it improves orgasm. That's basically the point of that.
Yes.
Is that right?
Yes. And we tell patients pretty quickly, you go have sex so we can see if this is working. It can take up to 90 days to really start to modify the tissue because, this is regeneration. But just amplify it with size and make it an easier target. That also is another, and that's partly why I love what I do, mixing it with urogynecology, because I sometimes tell patients, you got a long vagina. You got a really long vagina. And they're like, what? And I said, yeah. Is it hard to have an orgasm when your partner penetrates you? And they're like, yeah, but they're smaller than my other partners were. And I said, yeah, because they can't really hit a target. Like, that's part of the issue, is that the length of your vagina and your anatomy makes it a little different. And perhaps positions are also important when you have those alterations in anatomy.
Briana?
Yes.
On that juicy topic.
I love it.
I'm so glad you hit the mark right there. We are going to have to continue this another day.
Okay.
And I wanted to mention, before we leave the South Pole there, that you also do facial med spa kind of stuff.
Yeah.
So if you'd like to, you can come on back and we can talk about the other end of the spectrum.
Yes, North Pole, South Pole. I love it. I love it. Because when women trust you with their vaginas, they trust you with a lot of different things. So it has opened up a world for us, and I'm recruited some experts into my Medi Spa to make sure I'm a good steward of the space and I'm not crossing into territories that I don't know anything about. But from the standpoint of, just really hearing what a woman wants and hearing their desire to be their best selves, that's really the message I'd like to put out there, that, we're here to help you ask better questions and here to help you direct your therapies to get to the point where you're like, I like me.
I'm all on board with that. That's what I'm all about. So, and that's what my podcast is all about too. Wellness and wisdom. So I love to educate women, particularly about things they actually may not even have thought of. And as you said, when they realize that what they don't know actually hurts you, they will seek out more information and get to be their best selves.
Yes, they will.
So
thank you so much for having me. Oh, I had a great time. Thank you.
So let's see here. I'm going to say goodbye for now, and then we'll talk about the med spa situation.
Okay.
Maybe we can set a date for that.
Okay.
Thank you so much for coming on the podcast.
Thank you.
Thank you so much for joining me in this podcast with Dr. Briana Walton. Today, we talked about the pelvic floor, reconstruction, prolapse, urinary incontinence, sexual dysfunction, and the G-spot, among other things. I hope you enjoyed it. We talked about plasma injections of the clitoris, which is very interesting. And we'll have Dr. Walton come back and talk about other things that she does in her med spa. But from a urogynecology perspective, these are conditions that affect many, many women as they get older. And so if you don't have them, so much the better, but it's always good to learn and know what early signs are of any kind of problems. So welcome again to Wellness and Wisdom. And I look forward to talking with you on the next podcast. Bye for now.